Hello, everyone, and welcome to the next edition of the Sinonasal Cancer Collaborative. We're very excited for our session today, and we, of course, wanted to thank our host sponsors today, including the American Rhinologic Society, the North American Skullway Society, and the American Head and Neck Society. And special thank you to Wendy for organizing this for us today. The session focus today will really be a nice collaboration with our European colleagues. So we had a lot of very nice collaborations. We want to recognize them with this webinar today. This is really a collaboration with both the European Network for Sinonasal Cancer Collaboration, as well as the International Network for Sinonasal Cancer Collaboration. These are two groups referred to as EUSICA and INSICA, and they've been really active in both the research and the educational fronts. As you can see here, a number of nice publications, and want to recognize the leadership of those groups as well as we join into this webinar today. Our goals of these presentations are, of course, to illustrate principles in the management of sinonasal tumors. We're going to discuss multidisciplinary care. So that includes, of course, surgical care, systemic chemotherapy, immunotherapy options, as well as radiation options, and of course, a focus on comprehensive care and patient-centered care. Without further ado, I'd like to introduce my co-host for today, which is Ivan El-Sayed from the University of California, San Francisco. We're excited to have Ivan on board with us. And then our panelists today, so Dr. Carlo Restaghini, who is a medical oncologist specializing in head and neck tumors in Milan, Italy. Benjamin Verlon, who is our recent president of EUSICA in Paris, France. Esther Orlandi, a radiation oncologist specializing in head and neck tumors as well in Pavia, Italy. Sebastian Freilich, I think, will join us shortly, neurosurgeon from Paris, France as well. And finally, Marco Ferrari, head and neck surgeon, otolaryngologist from Padova, Italy. So we are very thankful for our panelists for joining us and look forward to much of your input throughout this webinar today. I do want to say a quick word. The next EUSICA-INSICA meeting actually takes place in Washington, D.C. at Bethesda, Maryland in March of this year, and that will be also joined by a cadaveric dissection course on March 20th and 21st. So keep an eye out for those dates if you're interested in joining for that meeting or for a training dissection course at the same time in March of this year in the DC area, specifically in Bethesda, Maryland. And with that, Ivan, I'll advance your slides, but I'll let you go ahead and begin with case number 1.
Okay, perfect. Well, thank you, and we'll get this going. So if you can advance the first slide. So this is a patient, an 80-year-old Cantonese male, presented with a 3-month history of a neck mass, actually, to our clinic. Actually saw an outside ENT who found a mass in the parotid gland and also a nasal mass at the same time. And it was notable that he had recently suffered from a cerebrovascular accident and was placed on anticoagulants for a thrombotic event. Can you advance the slide? CT scan was done, and it showed about a 2.7 centimeter lesion in the maxillary sinus that actually appeared somewhat destructive. And can you click on that? I'm not sure if that's a video of. Nope. Okay. But it shows the sort of destructive nature of the tumor, possibly. Also showed a mass in the parotid gland and bilateral nodes that were picked up. So if you can advance the slide one more time. So this is what he came into the door with us. He had a FNA of the parotid mass, which was Warthin's tumor, and a biopsy was taken in the clinic, which was reported as a sinonasal papilloma. And he was referred to our tertiary care center because of his medical complexity and the fact that this mass looked somewhat destructive on the imaging, and an MRI was completed. So this is the MRI scan, and so I'm wondering if we can kind of get a sense of what people are seeing. I think maybe if we can start with Dr. Ferrari, Marco. Can you weigh in here?
Yeah. So I can see a lesion whose epicenter is in the inferior and lateral aspect of the right maxillary sinus. And clearly the boundaries of the maxillary sinus have been surpassed by the lesion, which involved the cheek and infratemporal fossa, just underneath the temporalis muscle. So yeah, the diagnosis of inverted papilloma is not very much supported by this imaging. So I would probably consider repeating the biopsy at this point.
Does anybody else like to weigh in on this?
Yes, perhaps to add something, it seems that there are two components in the tumor, and in the nasal part of the tumor, there is this cerebriform pattern that could be the aspect of inverted papilloma. So this could be hypothesized that we have an inverted papilloma, which has turned into probably a squamous cell carcinoma in the lateral aspect. That would be an hypothesis.
Okay. Yeah, and so I think when we're looking at this this imaging, we all have this same concern. Can you advance the slide again, Garrett? And this might be a video, yeah, so let this run through. Just a little more demonstration of the lesion. We can see that the, well, I'll let maybe Benjamin, if you can weigh in, what are you thinking about here as you're looking at this lesion, suspicious that this might be a cancer?
Well, definitely, as Marco was pointing, the tumor is eroding the lateral wall and the posterior wall of the maxillary sinus. So this is not the aspect of a benign tumor of inverted papilloma. And well, the vast majority of cancers deriving from inverted papilloma are squamous cells. So in this case, that's why I think we can hypothesize once again that it's a squamous cell in this case. And it's invading the infratemporal fossa and probably the cheek. I don't see very well the anterior aspect, but the lateral extension is going into the fatty part of the infratemporal fossa for sure.
Okay, exactly. And that the other thing that I obviously looking at too, and I have the advantage as I'm presenting here, of course, evaluating the orbit, just evaluate if there's any if the orbit's threatened at all, if there's anything traveling perhaps up the lacrimal duct. So the orbit looks fairly clean to me, but definitely extending outside of the maxillary sinus. Can you advance to the next slide? And here's the adenopathy in the neck. Somewhat concerning when you look at this film. So let's go one more slide, please. And one of those was the Warthin's tumor. So we've had some suggestions of the diagnosis. The tumor location and the morphology, again, I thought it looks somewhat rising from papilloma. I would throw out a question here. Do you start to break down the potential pathology or type of tumor based on location of the tumor in the sinus, if you saw something in the ethmoid as opposed to the maxillary sinus? Maybe I'll throw that back to Marco for a second.
Yeah, sorry. Yeah, my understanding is whether there is a relationship between the epicenter of the lesion and the most likely histotype. And yeah, definitively, I think in the maxillary sinus, the most common ones are squamous cell and adenoid cystic, at least in our geographical areas. And what Benjamin commented on, I am very agree with. So the fact that there are these two signals, one suggesting inverted papilloma in the maxillary lumen, increases the chances disease is squamous cell carcinoma. In the nasoethmoidal region, the distribution of isotypes is quite different. And in our geographical areas, intestinal type adenocarcinoma would be the most frequently represented, and squamous cell is the second one, probably.
Okay. So what would be your next steps here for a diagnosis?
So I would repeat the biopsy, and considering the fact that there is this inverted papilloma-like lesion in the most accessible part of the maxillary sinus and nasal cavity, I would probably consider doing a biopsy through the oral vestibule in the portion of the lesion that has extended into the infratemporal fossa. Considering the extension of the lesion, I don't think this increases the chances of seeding because the tumor has already escaped from its original site. And I probably would also ask for a CT of the thorax and abdomen because there is a suspicious nodal metastasis. I wanted to make sure there are no distant metastases prior to treatment.
Okay, yeah, I think that's very reasonable, and that was our thinking as well. Can you advance the slide to the next? The other thing that we typically do is obtain the outside pathology and review it. I don't know if this is an issue in Europe to the same degree, but certainly want to have the pathology reviewed by a high volume center, high volume pathologist, because they might see something immediately on the pathology that was missed. We also thought that the neck nodes were pretty accessible too, that maybe we should try to needle those, but ultrasound showed that there was a fatty hilum. They looked reactive, and needle biopsy was done the same day in clinic, which showed that these are just reactive nodes. So we scheduled for biopsy of the mass in the operating room, and advance the slide one more time. Unfortunately, this issue of the cerebrovascular accident came back to haunt us. So he had had a stroke. There apparently were a lot of recommendations made by neurology and cardiology. They weren't sure of the origin of the stroke, if perhaps he had a patent foramen ovale. They wanted to get a bubble study. There's a number of things going on. And he was on anticoagulation orders that were very strict. And they wanted to keep that for another 6 to 8 weeks. And so anesthesia actually canceled our first attempt to take him to the operating room, and became a very big discussion of whether we should take him off the anticoagulation to get the biopsy. And so this is now, we're already at about a month and a half or 2 months from the time of his first imaging to the time it got to us. So I guess my next question is, would you proceed with the biopsy at this point, or what would you do? Would you wait these 6 more weeks to get tissue? And again, I'll let anybody weigh in that has an idea here.
Well, I guess we have 3 options. One is to wait. The second one is to do, as Marco was suggesting, a transoral biopsy, which is probably more easy in a patient under anticoagulant therapy. And the third option is to go through the nose. I don't know, for just a biopsy, I would consider that using, flow seal or something after the biopsy. Just for a biopsy, it's something that might be considered in our institution, I think.
Just keep on the anticoagulants and go for a biopsy.
Yeah.
My sense is that we need to go very deep to that posterior maxillary wall to make sure that we get tissue. And the transoral biopsy, how are you planning that? I'm not sure I understand. Would just be a Cabo Luck approach incision, or
No, I would have probably thought to how to say that, an incision into the vestibular mucosa, and then I would have slide through the lateral maxillary wall on the external aspect of it, and this would have probably led me to the extra maxillary sinus component of the mass.
okay.
This was the idea.
All right.
Yeah.
Yeah, and I think these are all reasonable. I certainly thought about it. I forget, he was on pretty good anticoagulant, I think Xarelto or something, So what we have at our institution, we have a really great radiology, interventional radiology. So I actually thought maybe we could try a CT guided. Ooh, did I advance it? I think I did. A CT guided FNA. So I was able to steal this off the the image, but they did come in somewhat laterally just through the skin. And once they got the diagnosis, they did take a core needle, which they didn't talk to me about, and I didn't think about it until afterwards. So maybe there's a risk of seeding here. But with the core needle, they were able to get a diagnosis. And so I'll move ahead in the name of time. So they diagnosed as keratinizing squamous cell carcinoma. It's HPV negative using immunohistochemistry, both for high risk and low risk cancer. So at this point, knowing that he's 80 years old, he's somewhat frail. This is a squamous cell carcinoma. I will now push it to maybe Dr. Resseghini. What would be your thoughts on how we should proceed with this?
Yes, thanks. In a vacuum, this kind of disease, very advanced, possibly responsive to chemotherapy. Induction chemotherapy might be an option to have both the treatment process, but this is in a vacuum. If you are considering age and the recent cardiovascular events, I think neoadjuvant approach might be off limits.
Yeah. And then Esther, Dr. Orlandi, do you have any other thoughts?
So I agree with Carlo. So we can propose a neoadjuvant chemotherapy and the local treatment according to the response to induction chemo. But in this case, we have adverse factors to prescribed induction chemo. So this case is resectable, I think. We have, so if we needed to do a stage of the disease. So I think that the overall stage could be T3 and 1 disease. I don't know if you agree about the stage, the overall stage of the disease.
I think we're calling the neck nodes negative at this point. They've been
Negative,
yeah, and the
negative.
PET
Okay.
scan is otherwise clean, and so no other distant disease. And advance the slide. I have to see what I have coming here.
Okay, so in this case, according to
One
the
more.
the guidelines, maybe we can propose upfront surgery followed by radiation therapy. So maybe the dose and the target volumes will be according to the histopathological reports. So we have to consider potential toxicity coming from surgery and concomitant chemoradiation therapy. So in this case, I prefer to propose a surgery instead of primary chemoradiation.
Okay, you can advance the slide there, Garrett. That's so
Okay.
the data on the induction chemo. So and this patient, I actually this is all fresh. He was in my clinic just yesterday, so we've not pursued treatment. But my thought is exactly that. Given his medical frailty, maybe we can do induction chemotherapy, and then if he has an excellent response, we would kind of proceed from there. But sometimes the things that make him medically frail for surgery also don't bode well for chemotherapy. And so they bounce that back to me. But let me ask our two surgeons, what do you think about resectability on this tumor?
Well, I believe that it is resectable, and I personally think that the orbit won't be that much of an issue in this case. I would probably consent the patient for an orbital floor resection plus primary reconstruction with a titanium mesh or something like that. But I think the challenge is actually in the infratemporal fossa. I would include the temporalis muscle in the resection and the upper part of the cheek to get a negative margin there. And the other challenge would be the posterior margin, which in our hands is usually controlled through an endoscopic transnasal approach. And it would include the entire pterygoid process and muscles.
Dr. Verlaud, any other thoughts on that?
No, Marco is perfectly right. And well, in this case, you can appreciate the inferior orbital fissure, which is a critical point in these maxillary tumors. You want to check that there is no invasion of the orbit through the inferior orbital fissure. In this case, it seems to be clear. The pterygoid process is intact. I think on CT in the first slide, we saw that pterygoid plates were not invaded, not eroded. So in this case, probably we would go also for surgery. And as Marco was saying, with a combined approach using the endoscope for the upper limit and the resection, the section of the pterygoid plates through the endoscopic view.
Yeah, yeah, and exactly many of my thoughts. I'm a little concerned about the extension inferiorly. It looks to me like it's pushing down and maybe growing down, but not invading. So there's a good chance we can save the palate. My experience, though, is that that tissue invasion into the muscle, the pterygoid fossa there, we really can't predict ahead of time if we're going to be able to clear those margins or if we're going to have microscopic positive cells sort of invading throughout. And it's not a lot of space or tissue once you really start getting into it. So for those reasons, again, I would favor induction chemotherapy. We typically think of it as trying to save the eye or the orbit or save an organ. But I'm looking at this here and thinking that it could help me achieve, a clean margin posteriorly. And then the thing that we've been seeing recently is some of these patients we send for induction chemotherapy. What if at the end of therapy you have a complete response? So my last question here, and we'll get to the next case, is if you have a complete response, do you still recommend surgery or do you go straight to radiation or chemoradiation? So I'll just run through the panelists one by one. Marco, what do you say?
Well, there's no data to support that, but we would recommend chemoradiation in that specific case.
Yeah. Carlo?
Yeah, if I remember correctly, there might be some few data from the MD Anderson case series on first name, I guess, Contreras, in squamous cell carcinoma of the paranasal sinus. And you have some data supporting what Marco was saying about skipping surgery and going to chemoradiation.
Yeah, and Dr. Verdeloud?
We'll do the same.
Okay, and Dr. Orlandi, what do you think?
I agree. So we have a few data about squamous cell carcinoma compared to undifferentiated carcinoma, although we have an abstract presented to the last ASCO, if I remember, for the first phase 2 trial from the MD Anderson with potential benefit in giving chemo radiotherapy in case of good response after induction chemo.
Okay, yeah, and again, the data is not quite there, but there's cases we've gone in and we get no tumor in the specimen. I think what I do sometimes I might go in and clean it up endoscopically just to see how much tumor is around, and if I'm not going to cause a lot of major damage. But with a complete response, I'm definitely leaning more and more towards going straight to radiation now. Okay, I'll finish there and pass it off to Dr. Chobe.
All right, Ivan, great case. Thank you so much for sharing. So we're going to move on to case number 2. And yeah, so this is actually a 79-year-old woman. So similar to the first case, a bit of an older patient who was initially referred to me for a large nasopharyngeal mass. She had had a little bit of nosebleeds, then really nasal congestion and blockage was the major symptom for a few months. Instantly, she had lost a couple of pounds. She was, about 150 pounds soaking wet. Pretty healthy otherwise. So a little bit of hypertension, hyperlipidemia. Otherwise, she was a healthy 79-year-old lady. She was active, completed all of her activities of daily living, besides some minor blood pressure and hyperlipidemia issues. So she actually had an outside biopsy completed. The outside biopsy initially was read as a carcinoma, but they actually favored a squamous cell carcinoma. I'll show you her imaging in a minute here. That being said, we had it reviewed here and it's a little less definitive. So I actually took her to the operating room and took a larger, more definitive biopsy to get better tissue for her. I will note in that OR biopsy, we did see some skip lesions along the nasal septum in the inferior turbinate, just a note as we sort of preview things. That biopsy returned as a mucosal melanoma. We did get molecular studies done in genetic testing. There was no identifiable mutations, in particular, no BRAF mutation. We do not get circulating DNA on a lot of patients, but some of my medical oncology colleagues do like it. This patient did get an upfront circulating DNA, which was negative. So here is her imaging. We'll start off with a CT scan. And what you'll see here, as I sort of just in the interest of time, I'll kind of scroll through a little bit, a fairly large nasopharyngeal mass filling the majority of the nasopharynx, at least contacting, if not invading, the nasopharyngeal tissue there. Posterior septum involved in sort of the bilateral inferior turbinates. Maybe a little bit of erosion on the pterygoid plates there as well. Okay. For completeness, here is her coronal image. Not much nasal cavity. In the posterior right nasal cavity, you're seeing that tumor. Scroll through a little bit. And again, perhaps a little bit of pterygoid erosion there as well, and mainly a nasopharyngeal tumor. Here's her PET scan. Just to scroll through again. She did not yet have an upfront MRI scan. So no regional or distant disease. Again, there's that PET again. At this point in time, we were kind of a few weeks out from getting an MRI scan, so I don't have an upfront MRI scan for her, just for completeness sake. A quick shot of that CT scan as well. Again, a bit of perhaps some right pterygoid erosion involvement there along the skull base. So from a staging standpoint, as you guys know, mucosal melanoma is either a T3 or T4. She's kind of a borderline T3, maybe a T4A if you count that pterygoid erosion, but sort of a T3, T4A patient, again, N0, M0, no genetic mutations. So with that, to the group, and Marco, I think I'll start with you if you don't mind. Let's talk about treatment options. So again, a 79-year-old patient, a locally advanced mucosal melanoma, no regional or distant disease. What are your initial thoughts on next steps in treatment for her? And I think we have some options. Certainly the surgery, there's systemic therapy options, there's non-surgical options. What are your initial thoughts here?
So I believe that we should start saying that the lesion that you showed is resectable with a surgical operation, which is not that demanding for the patient in terms of adverse events and toxicity. So that is one point to be considered. The other thing is, we know this is a paradoxical disease. It shows exophytic growth pattern, but at the same time, some satellites were seen in the septum, in the turbinate. So this clearly something that grows beyond our ability to see it, even locally. On the other hand, nowadays in Italy, I don't think we have that many options apart from starting with upfront surgery in terms of systemic treatment, because we should declare it as a non-resectable disease to get access to other sort of systemic treatment. And please, Carlo, amend what I'm saying. Carlo lives in the same country where I'm working. And the other option might be to consider a definitive and radiotherapy treatment here. And I would discuss it with my radiation oncologist and those working in facilities with particle therapies for that. And yeah, I think that it very much depends also on the patient's condition and expectations and willingness to undergo surgery. In my clinic, this patient would be proposed upfront endoscopic surgery plus adjuvant radiotherapy, which will be something taking a place into the first conversation with the patient, because we believe that adjuvant radiotherapy is an important part of the treatment in these cases.
Yeah, very, very good. And we'll certainly tap in a minute here. Carlo and Esther as well to comment on those things. Benjamin, I know there's been a little bit of work done, at least trial-wise, in France as well, as I recall. Marco, I agree. Both those are all very good options. Any other thoughts there, Benjamin, or things you wanted to bring up as far as other upfront options?
Yeah, well, the idea is that half of the patient with sinonasal melanoma will have distant metastasis within a year. So it makes sense to consider systemic therapy in these patients. And in France, we are using induction immunotherapy. And actually, in some centers, it's been also discussed using combined double immunotherapy. In this 79-year-old patient, I think it's probably not very easy to do a combined double immunotherapy. So probably we would just choose anti-PD-1 induction immunotherapy in this patient.
Okay, very
and
good.
then we would go for surgery, and well, we'll discuss the rest probably later.
Sounds good, thank you. And we'll get a really good point on the tolerance of dual agent therapy in certain patients. We'll get to that in a few minutes here. Carlo, you mind just offering some insights? I know that different countries have different protocols and availability of different things, but any thoughts there on immunotherapy or other systemic therapies for this patient?
Thanks. So, as Marco was saying, there is a regulatory aspect that should be kept in mind, but at the same time, we have the issue of data. What data do we have to build on the what Benjamin was saying, that we have to consider this mucosal melanoma as a systemic disease for several reasons. The skin metastasis, the distant metastasis that we see very soon after the diagnosis of those patients. So the systemic strategy upfront is something important to consider, and we are starting to build evidence in the mucosal melanoma field that are not quite at the same level in terms of positive results as in the cutaneous melanoma. For cutaneous melanoma, when we are talking about induction immunotherapy with a single agent, we have recently published a trial where we have over 60% of patients benefiting from immunotherapy, with 56% achieving major pathologic response. For mucosal melanoma, either with single agent, multiple immunotherapy agents, or with combination of target therapy and immunotherapy, which is another strategy that is ongoing under evaluation, we have response rate that are always below 40%, and therefore we are not talking about such a sensitive disease. But at the same time, the need is there. So we probably do not have the right answer right now. We're doing what we can with what we have. And if we do not have any option because of regulatory issue, we might go around the regulatory issue, stating as a multidisciplinary team that there are probably less chance of local control. So we are able to, with surgery, so we are able to still deliver immunotherapy to those patients by declaring them not suitable for surgery for whatever reasons. And so 79 years old, in this case, it's an advantage rather than an issue. But other than this, we are at the point where we have to build up evidence and find out an effective treatment for this setting. I think Esther might want to add something.
Esther, I wanted to get your insights on, the radiation for this disease process. There's some mixed data out there as far as maybe not increasing overall survival, but certainly improving local control. But certainly interested to get your thoughts on this disease and the role of radiation, either in the primary or in the adjuvant setting.
Okay, so we have distinguished resectable cases and unresectable ones. So for unresectable cases, the addition of radiation therapy in adjuvant setting improves local controls for sure. We have retrospective data, but we have to give adjuvant radiotherapy in mucosal melanoma of the head and neck. This is a high risk situation. So we have to give adjuvant radiotherapy in order to improve local control. Regarding to the impact on overall survival, we have a trend of improvement, but so the major advantage in giving adjuvant treatment is in improving local control. So in any cases, when we have a mucosal melanoma, in resectable stage, we have to give adjuvant radiotherapy with, I agree with Benjamin and Marco, with systemic treatment, pembrolizumab and nivolumab. In case of unresectable disease, so remember that mucosal melanoma is very radio-resistant tumor. So if we can use conventional fractionation in adjuvant setting, in case of unresectable disease, so in case of definitive radiation treatment, we can use two different approaches. So with photon-based radiotherapy, we need to give hypofractionated disease. Or we can use protons or carbanion therapy, so particle therapy, in particular carbanion therapy in light of their superior so biological effectiveness. We have data on carbanion treatment for these tumors, and we have observed an improvement of about 30 percentage points in local control by using carbon ion therapy in a resectable disease. So if we have a particle therapy, protons and carbon ions, we can use these kinds of beam energies. However, in case of a photon-based IMRT or volumetric modulating art therapy, I suggest to use hypofractionated regimen in light of the radio resistance of this disease. In any case, for a resectable disease, we in Italy we give immunotherapy before, radiotherapy in definitive setting, and immunotherapy after radiotherapy treatment in order to improve local control and overall survival. So just regarding to your question, in the last 3 years we get molecular testing for these patients. So in particular, BRAF and KRAS mutations.
Okay. Awesome. Thank you. Very, very good insights. Really appreciate it. I'm going to just go to the next slide in interest of time here. So as far as this case progression goes, we discussed all those options, including upfront surgery, upfront systemic therapy as well. We discussed both dual agent and single agent. We favor dual agent when at all possible, typically a PD-1 inhibition, a CTLA-4 inhibition as well. She had good ADLs, was pretty healthy besides her age. So we went ahead and gave her 2 cycles of dual agent therapy with the goal of preventing hopefully systemic disease and then bringing her to surgery as well. So here was her repeat imaging, again, an MRI scan. Her repeat PET scan showed, again, no regional or distant disease. Here is her updated MRI scan after dual agent immunotherapy induction. So again, I'll scroll through there again. So I think we could suffice to say she had a favorable response, not like a 50% reduction, but tumor smaller, and certainly I think continues to look resectable. I will say that we do favor an aggressive surgical approach in these patients, given the high chance for, as Marco alluded to, sort of skip lesions and things growing behind the scenes, if you will. In interest of time, we'll move some of these questions relatively quickly. Marco, just maybe a quick synopsis. If you were going to take this patient to surgery now after the immunotherapy, what surgery would you offer her based on that imaging study?
Well, the honest answer would be I don't know, because we don't have really experience with that. But I would probably resect all the clinically appreciable tumor, focusing on the pedicle of the lesion. Often this lesion are pedicle somewhere in the septum, probably in this case. And if I see satellites in the mucosa, I would also perform in the mucosa or other parts of the sinonasal tract, I would also perform a mucoperiosteal resection in that portion. I would not be too aggressive and remove also the underlying bone. But yeah, for certainly, if I see brownish spot on the contralateral nasal fossa, I would also remove them. So that would be the target of my surgery.
Benjamin, any other quick insights there on a surgical approach?
Yes, just like Marco was saying, it's important to limit probably the morbidity in this patient. So we would go for a resection of the involved areas, but without resection of major structures. Once again, this is a systemic disease, and it makes no sense to be very morbid on the tumor site.
I think we covered a little bit about the adjuvant radiotherapy. Carlo, I just wanted to ask you, so this patient again got, in this situation, induction immunotherapy, dual agent, got surgery. Would you then give additional immunotherapy afterwards? And if so, for how long? A month, a year? What would be your general regimen there?
Well, as I was saying before, we have to mutuate part of the evidence from the skin melanoma. And so adjuvant immunotherapy makes sense, especially in light of the response to the, even though partial, to induction immunotherapy. I would probably stick to a single agent, given the age of the patient and the risk that we are exposing her to, and the lack of evidence. So the relationship between all those things makes me lean towards a single agent immunotherapy up to 1 year.
Okay, very good, excellent. And then again, in interest of time, I'll kind of just show some case progression here. So this patient got an endonasal surgery, a relatively low morbidity surgery. We were fairly aggressive locally. She had a transpterygoid approach to take out that pterygoid portion of the tumor. Her Vidian nerve was involved. We know that positive margin, of course, is going to lead to potentially recurrence and or distant disease. So we did resect that back to the lacerum carotid. But again, no orbital resection, nothing like that, a fairly low morbidity surgery, but again, aggressive endonasal surgery. Here's her post-operative scan. We covered that carotid with a septal flap. So this patient, for better or worse, developed shortly after surgery ICI-related pneumonitis. So as I think Benjamin mentioned early on, the side effects of immunotherapy are not insignificant, especially dual-agent immunotherapy. So she was actually hospitalized for about 6 weeks with this pneumonitis, then was eventually discharged. Esther, she did get adjuvant therapy locally. No, we did not cover the next, but got local adjuvant therapy radiation-wise. Because of her pneumonitis, we did not do additional immunotherapy, although, Carlo, we would typically favor, as you alluded to, single-agent immunotherapy for about 12 months afterwards for a good response. But of course, given her side effects, we did not. She's now about a year out. She's been NAD, got a PET scan last week and still looks clear. So knock on wood, we're cautiously optimistic with her. And so far doing well. So with that, Ivan, I'm going to turn it back to you for case number 3. I know you got to show from your computer, so
Okay.
I'll go ahead and let you take over the screen share.
All right, great. Let me replace you. And you can see my...
Yes, we have your slides. Yep, and they're full screen now, Ivan.
Okay, perfect, great. All right, well, I'm going to move on to case 3. This one has a lot of slides, so I'll move through some of them in the name of time. And just to give a flavor. So this is a 49-year-old male who is referred with a maxillary sinus mass. Had a 1-year history of something going on. He had had 6 teeth removed due to loosening, developed facial numbness. That's been about a year out. Feeling of a right ear blocked, and actually developed a lump on the side of his head. Then he got nasal obstruction, so it became a sinonasal cancer case, and started having some epistaxis. He, of note, denied any visual difficulty and no other cranial nerve symptoms. On physical examination, he did have some decreased sensation, about 60% of the right V2 area. Fluid diffusion was noted. He had some trismus. All other cranial nerves are intact, and there is a visible mass just about to come out of his nose. And a biopsy was taken on the outside. And God bless them. It was diagnosed as a cholangioperiocytoma, which, as I think most of us will know, is a vascular tumor or tumor of blood vessels. So I'm sure there was a significant amount of bleeding encountered in the office at the time of the biopsy. So let me run through the films here, and hopefully this will advance. So this is the mass we're seeing on the axial. You can see it's a rather large mass filling the maxillary sinus. It goes up to the orbit, along the orbit. Here we're looking at the coronal sections. You can see, I'm going to come back right about here, if I can freeze it. You can see it's sort of wrapping around the eye. I don't know if you're seeing my pointer here, but extends beyond the confines of the maxillary sinus. And we'll go to the next slide here. This is highlighting the area around the middle cranial fossa, greater sphenoid wing. You can see some loss of the bone continuity, enhancement here. Looks like there's a little rim of bone there, and our determination is that the greater sphenoid wing is actually thickened with tumor involvement. And so that is just up to the dura. You can see it's sort of wrapping around 270 degrees around the orbital apex region here. There was some question of whether or not this enhancement here is actually frank dural invasion, and in some discussion with the radiologist, it's actually not. There's bone invasion. It's up to the dura. This is a little trickery of the imaging, but just early on, thinking is that there's just gross invasion of this tumor intracranial here, but this is still a rather extensive tumor, and you can see it extends down inferiorly in the peripharyngeal space, just kind of tracking down beyond the confines. So, to recap, this is a massive tumor in the maxillary sinus, sort of centered around the maxillary sinus, involving the infratemporal fossa and the peripharyngeal space, involving the greater sphenoid wing bone, possibly up the dura along the middle cranial fossa, surrounds the orbital apex around 270 degrees. No gross invasion of the orbit, and his eye function is completely intact, completely normal. So this is what he comes in the clinic with, and the diagnosis is reportedly cholangioperiocytoma. So first question out to our ENT surgeons, who would want to rebiopsy this? Marco, yeah, and Benjamin as well. And I assume is this something you would do in the operating room?
Yes, I would I would personally do it in the operating room, being sure that I provide as much as material as possible for my pathologist.
Yeah. And then, of
Yes.
course, the risk of bleeding as well as the.
Yeah, it's really the first step for the whole decision process. So you really need to have a proper histological diagnosis.
Yeah. And so this was the biopsies were taken in the operating room. It's a very vascular tumor filling the nasal cavity into the nasopharynx, kind of growing posteriorly through the nasopharynx. Typically, sometimes I'll try to see if I can get them to breathe or make them a little more comfortable. And this is just not possible at this scenario because it's such a vascular tumor. And so the preliminary diagnosis about a week out was that this is a spindle cell carcinoma. And so I don't know if Carlos, if you'd like to weigh in your thoughts about a spindle cell carcinoma at this stage.
Sorry. Well, I can see that there are further pathology evaluation going on. So I would like pick up my phone and start stressing my pathologist to get any information I can.
Yeah,
So
yeah, and so because this
that's
could
my
still turn out
suggestion
to be
for everybody.
it
Get
could be a number of things,
good
but it's
conversation with your pathologist each
yeah,
and every time.
yeah, and
Ivan,
spindle cell.
I'll briefly mention too, really importantly, we've all showed every case we've had so far, the importance of an expert high-level pathologist is critical for sinusal tumors. So that's a really good point. I just want to highlight that. Like our pathology colleagues are absolutely critical parts of our team.
Yeah. And so, of course, in the meantime, while we're trying to sort this out, he shows up back into the emergency room, and every note says, after the biopsy, he's had bleeding. So I am now accused of causing a major bleed. But he came in with significant epistaxis and had to go to IR to get embolized. And in the way of thinking, and ironically, this happened while I was at the North American Skull Base Society meeting. So I was out of town and not able to assess him. But they took him to the OR, and this looked like a massive unresectable, and I think they were thinking squamous cell carcinoma, spindle cell variant. And so they actually gave him a round of intraarterial chemotherapy before they embolized this. So I do want to, this is not a talk about intraarterial chemo, but Carlos, can you weigh in about your thoughts about intraarterial chemo for maxillary sinus or head and neck tumors?
Yeah, we have some experiences, especially from Japan, on intraarterial chemotherapy for maxillary sinus carcinomas. It's quite challenging in terms of the technical involvement in this technique. So it's not for every center. It's not the standard right now. If there is experience in your center and probably better, even better, a clinical trial evaluating this kind of technique in a proper setting, this might be a topic for evaluation and then there's an option for a patient. as
Yeah.
a standard practice, I'm not feeling that much of a recommendation for this this kind of technique.
What I would say, I
And I
think,
understand this is a situation where the patient presented himself bleeding, so you have already catheter in the lesion.
Yeah.
And
I thought they
understand the
think
temptation.
before they clot it off, get some chemo in there, and they have them right there. So we do have a team that is actually very skilled with this and really pushing for this. And so I highlight it because there is some really interesting data coming out of Japan now that I suggest everybody take a look at. And it is giving some pause as to the best way to treat this, but we will consider it for unresectable aggressive tumors really don't have anything, but it's not straightforward because you get a very large dose of cisplatin. You could have renal failure or other issues come, and you have to ask, is it better than systemic therapy? So I think there's a lot to be worked out and to be considered for this, but I'm just putting that as a little something on the board there to think about moving forward. He did have a port place.
If I may, of note, they performed intraarterial chemotherapy when the surgeon was out of town. So
Yeah, it's a work in progress. But we've been meeting and forming a group, and so there's a group forming if anybody's interested in pursuing that. At this hospitalization, not at this minute, we thought that this airway compromise, risk of bleeding, some trismus, difficulty getting into his airway, that he might be better served with a tracheotomy, which is something I rarely ever do in my practice. But this seemed like a wise thing because we still weren't sure of his treatment plan. So I'm going to move forward to the next slide. PET-CT was completed. There's no evidence of metastasis. Of note, the lesion didn't show up at all on the PET scan. It's completely non-avid. Final pathology came back is a synovial sarcoma. I had a gene rearrangement that is pretty classic for it, and this was staged a T4A high-grade tumor. The bleeding was controlled. So at this point, and I highlight this, I like when I talk to residents about this, that there's 72 types of tumors that occur in the nasal cavity, and most of them come from other areas that we ignore. There's only about, I think, maybe less than 20 primary sinonasal tumors, but we see them all. And so whenever something like this comes in the door, even after years of practice, I have to go and look each one up, and it's usually changed since the last time I've had to encounter something like this. So I'm not expecting anybody to know the answer to these right off the bat. But does anybody have any thoughts about sarcoma in general in this scenario, and then synovial sarcoma? And so, Carlo, I'm going to start with you as the medical oncologist because that's the first person I have to call.
Yeah, sure. So first of all, disclaimer, I'm more involved into epithelial kind of tumors. So sarcoma is not actually my field, but I just I had just a call with a colleague of mine who is involved with sarcomas, and we agreed that in a situation like this, an induction chemotherapy, preoperative chemotherapy might be an option, especially with agents specific for sarcoma. So cisplatin, it's probably not the best option, but rather ifosfamide and epirubicin might be the best scheme in a situation like this.
Okay. Yeah, and so that the perfect point, I even put a slide on there. Who do you consult in this? So we have our usual head and neck tumor conference, medical oncology, radiation oncology, and they're epithelial experts. So we actually have a sarcoma team, and that requires a second call on a separate tumor board. And I'm just wondering, is it general practice across the world that everybody has a head and neck tumor conference? Is it done the same way, or is it more institution specific?
Yes, I think so. It's a pretty common practice in high-volume centers.
So maybe for this case, we can we can discuss with the sarcoma team for sure to give an induction chemo. So an induction chemo based on doxorubicin ifosfamide, for example. So I think that in this case could be considered unresectable. So,
Yeah. Yeah,
okay.
this is not
So
something that we feel we could resect at this point.
okay, so for this very interesting case, so maybe I would discuss chemotherapy. So as you know, for radiation therapy in the in sarcoma of the head and neck, we can discuss between preoperative, postoperative in resectable cases, but here, so I think that after induction, we can reevaluate the case with surgeons and with medical oncologists and radiation oncologists. I'm not sure that because synovial sarcoma is very chemosensitive tumor, so maybe we can think to have a good response after doxorubicin or
Yeah.
so
So, what are your thoughts on and how do you call it, neoadjuvant or induction radiation, preoperative radiation?
neoadjuvant preoperative radiation. Okay.
Yeah, so our sarcoma expert actually proposed to us that given this is unresectable, perhaps we could give preoperative lower dose radiation with chemotherapy with the goal of making this potentially resectable. And so it was with Dr. Rubenstein and IFOS. This is a study. It's not a large study, 46 patients in the in the extremities in the body, and their goal here was to make unresectable tumors into a resectable tumor, and they had a 70% R nod or zero resection
Okay.
rate.
So
Um,
I fully agree, but for the soft tissue sarcoma of the extremities. So for the head and neck, the data about preoperative, postoperative are conflicting. So for example, we have data from the MD Anderson published last year. Um, the authors concluded that giving a postoperative radiotherapy is associated to a lower rate of complication, for example. So
mhm.
other authors concluded in the opposite way. So, but just to underline that, in my opinion, preoperative radiation therapy in head and neck needs to use conventional radiotherapy. So give me five fractions in with the 5 grays. So for sure for sarcoma of the extremities, but I recommended more caution for the head and neck area.
Yeah,
So
yeah.
just
And I think our radiologist is thinking more like you. So she actually got a full course of radiation, or at least the 5,000, but I think higher. And there's just a little note of synovial sarcoma to bring everybody up to speed because I had to look it up myself. 8% of all sarcomas, usually in the extremities, usually they have this translocation, sorry, of the gene. About less than 50% have 10-year survival. They do metastasize, and the treatment of choice is wide local excision with radiation and chemotherapy. Prognosis in the head and neck is less certain because there's less data on it. Um, so we did, and the treatment plan sort of changed. First, we started off induction chemo, and then we decided to do the preoperative radiation, completed a course of radiation preoperatively with the plan for surgery if he responded. And he did actually have a fairly good response, but we can see this tissue sort of along the orbit, a lot of tumor regression here, some enhancement out in the temporal fossa out laterally, and really hard to tell exactly what's going on. So we did opt to go with a surgical approach here, and so this might be a little, this is, gets out of the sinonasal cavity as well. I don't know, and we were hoping we had a neurosurgeon here today as well. I don't know if anybody has any thoughts about how they would approach this. And I don't know, Marco, Benjamin, would you call in a colleague, call in like a, you know, the friend, a combined case? What would be your thoughts on this?
Well, we would certainly do it with a neurosurgeon. We have also quite a strong lateral skull-based team, which is composed also of some ENT dedicated to auto surgery and auto neurosurgery. And I think based on the imaging you showed before, so the pre-chemoradiation imaging, probably a middle cranial fossa approach would have been considered. I don't say more than considered because I have no expertise in that to be combined with something anterior or anterolateral, either a transfacial approach or something combined with an endoscopic approach also. But yeah, for the posterior part, I think it's rather difficult to control it completely with a decent margin, only with an anterior approach. So certainly there would be something to be added from the lateral side.
Yeah, and that is exactly what we were thinking. So we did a combined orbital approach with a transnasal approach, and you know, to be honest with you, most of the resection is done through the OZ approach here. This is one of my favorite surgeries. So we perform this a number of reasons, but we track this out along the floor of the orbit into the sphenoid sinus, to the posterior maxillary wall, to the pterygoid plates. That tumor extending down to the parapharyngeal space is all through this area here. You can see here's the orbit, you know, kind of just completely exposed. And we circumferentially peeled the tissue off off the orbit, but it was maintaining its position. And then endonasally came out anteriorly, addressed the sphenoid sinus, the remaining sphenoid sinus, the medial maxillary wall. The nasal septum was removed. The anterior skull base appeared clear, thank goodness. And then we basically tucked in an anterior lateral thigh flap through the hole here, and I pulled it into the nose endoscopically and laid it in. And interestingly, let's move on here. Pathology revealed minimal tumor left in the infratemporal fossa specimen, but the tumor along the middle cranial fossa was clear. Everything we removed off the orbit was clear. The sphenoid sinus was clear. So I think this was about, like, everything at the margins was clean. It was about as good as a home run as we could get. And this is him. This is his postoperative appearance. His vision is completely intact. I like to make these little 3D VR models, if you notice, by the way. So, and his imaging, this is with the ALT flap in place there. Does anybody have any comments? Benjamin, do you have any comments about the approach there? Or?
It's very impressive, fantastic. No other comment. No, but I
Well,
was
again,
very,
I relied on my neurosurgeon to you know, create that wide opening for me. That's our part's easy at that point.
I was very interested in the definitive pathological response, because it's very easy to tell when you see the post induction treatment imaging. You don't know what's invaded or not. So I'm very
The
impressed
tissue
by
was
that.
like glue, like you just couldn't tell what was what. So I basically removed anything that was, you know, fibrotic scar. And you know, thank goodness the stuff in the middle was where the cancer was at. So Dr. Orlandi, do you have any thoughts or assessments after the fact? I think the point you brought up about the complications is one of the major you know, issues with the preoperative radiation plan. Dr. Orlandi, are you there?
I was wondering about the radiotherapy regimen used. So I was wondering that maybe you can move also in Italy to use more hypofractionated regimen also for the head and neck. So my comment.
Yeah, I'm not exactly sure. I know that the total was 5,000 gray hairs IMRT, and it was a 5 week, several or maybe more course. It was a full course of radiation.
5 weeks, so the classic, typical preoperative 70 grays in 25 fractions. But maybe you can try to move, so 5 grays in 5 fraction is too much. But maybe we can use intermediate hypofractionated regimen, so in 13, 15 fraction instead of 25. But so the radiation oncologist used the conventional fractionation in this case with an excellent. So overall, the overall strategy was excellent.
Yeah. And I will say for case in point, we see several sarcomas and they all seem to have a different answer. Some just seem to be completely radiation insensitive. Surgery is the only answer. And so I was surprised when they suggested that for this type. So it's very important to have a sarcoma expert and expertise evaluate the case. And then Dr. Ruschini, any other thoughts on this, or would you have done something differently?
Since this is not my area of expertise, I would have picked up the phone right away and did exactly the same. But in any case, I think this is probably other than the cisplatin, intraarterial cisplatin, I think this is the correct management of this kind of case.
I think
Okay.
Marco, you had your hand up too.
I was just curious if he received also adjuvant chemotherapy or after treatment.
I think the plan was for adjuvant treatment after surgery, but given the pathology findings, they decided to observe. And so he's about 13 months out. He had this is a huge tumor. He's not out of the woods. If there's a recurrence here, I would not be shocked. There's a little something on the edge of the flap that caught our attention, and a biopsy was performed of that with a CT guided, and that was negative. I believe there was a nodule there. And everything's been stable between the interims, first detection of that nodule. But we keep a very close eye on him. But given that the pathology really looked like we cleaned it out, he was not given further treatment.
Awesome. All right, awesome. Great case. I think in the conclusion, we'll wrap things up. Really wanted to say a sincere thank you to all of our panelists for your expertise and insights today. So appreciate you joining at your various time zones. Thank you again to the ARS, the NASBS, and the AHNS for co-hosting this. And appreciate everyone's time. So thank you very much.
Thank you.
Thank you.
Bye.
Yeah.
Bye bye.